Katz. I'm CEO and founder of Life365, and welcome to Season 4 of The New Normal. In today's episode, we'll discuss ways in which several organizations are helping to increase quality and access to care for veterans and technologies being leveraged to recognize new opportunities for improving care. Before introducing our panelists, I want to take a minute to thank you for watching today, as well as thank our panelists for sharing their time with us as well. All recordings from the New Normal webinar are available on www.newnormal.buzz and your favorite podcast streaming sites. Now to introduce our distinguished panelists. Dr. Scott Wise, CEO of Valor Healthcare, is a U.S. Army veteran. He's president and CEO of Valor Healthcare and a graduate of the University of Texas Southwestern Medical School at Dallas. He holds an MBA with a focus in healthcare administration from the Eisenberg School of Management at UMass Amherst. After leaving the Army in 1998, Dr. Wise was in private medical practice for 10 years before joining Valor in 2007. He has held successive roles at Valor, beginning as a clinical medical director before being named the company's chief medical officer and chief of staff, chief operating officer, and now president and CEO since 2014. Welcome, Dr. Wise.
Thank you, Kent. Good to be here.
Great to have you. And next is Dr. Uohara, is Chief Medical Officer of Microsoft Federal. Dr. Uohara is an accomplished healthcare technology, health IT leader with clinical research and management background. He has a successful track record of digital transformation and bringing digital and virtual solutions to market. He is an expert in strategic implementation of enterprise platform-based solutions and programs, having created and led the implementation of solutions for commercial payers, large healthcare providers, and government healthcare entities. Dr. Uohara received his bachelor's degree in business management and economics from Babson College in Massachusetts and earned his Doctor of Medicine from the Temple University School of Medicine in Philadelphia. He has served on boards and committees of healthcare innovation, technology, research, and development. He currently serves as Microsoft's clinical lead in the federal healthcare space. So welcome, Dr. Uohara.
Thank you for having me, Kent. It's a pleasure to join you.
So, really quickly, I just wanted to go into your background. So let's go with Dr. Wise first. Can you just kind of provide a brief overview of Valor Healthcare?
Yeah, sure. Thanks, Ken. Valor Healthcare is a nationwide federal government healthcare services contractor. We have contracts with a number of departments and/or agencies, including Homeland Security, Customs and Border Protection, and the Walter Reed Army Institute of Research, for example. But our largest book of business is with VA, Veterans Health Administration specifically. We design, build, staff, and operate community-based outpatient clinics for the VA. And over the years, we've built well over 100 of these facilities for VA. And today we operate over 50 locations across the country. In those sites, we do over 500,000 primary care, chronic disease management, and mental health outpatient visits every year, taking care of about 170,000 veterans, which makes Valor Healthcare second only to the VA itself in the direct delivery of primary care services to America's heroes.
Wow. So explain to me, I keep on hearing about CBOCs right out there. So explain to me what one of these CBOCs look like. Do you have, I think you are in over 50 CBOCs or more?
Yep, today,
right?
Yeah, today a little over 50, yep.
Yeah, and so what does the CBOC look like? Are they in small towns throughout the United States, or are they in bigger locations? It's
pretty easy to picture if you think about kind of a hub and spoke setup. Back in the late 90s, Congress basically said to VA, you do an awesome job taking care of veterans if they happen to live close to one of your VA hospitals. We think you could do a better job taking care of veterans if they don't happen to live close to one of your VA hospitals. And so the CBOC, or Community-Based Outpatient Clinic Program, was born of that effort. And the design and goal of the program is for these clinics to be in the communities, often suburbs, where veterans live, usually at least an hour, sometimes 2 or 3 or 4 hours away from the VA hospital, so that they don't have to make that drive all the time to see their primary care provider. And there are 160 or so VA medical centers across the country, and around each one, out in the communities, it could be a suburb like here in the Dallas area. We have a clinic in Denton, which is a very large suburb, 2 universities there. But at the opposite end of the spectrum, we have clinics, for example, in places like rural Louisiana, which is 2 hours perhaps from the VA medical center, and we have a clinic in Durango, Colorado, for example, which is actually attached to the Albuquerque, New Mexico VA, and those veterans would have to drive 4 hours to the VA medical center to get primary care without the CBOC program. So it's a really, really huge benefit in my mind for veterans to be able to get their primary care, and now behavioral health and even some specialty care kind of in their communities.
Right. Michael, I'm going to go to you in just a second, but interesting enough, this had to be some years ago, but I actually did personally testify in front of a congressional subcommittee on veterans affairs for rural and highly rural veterans, and how that, they exacerbate their disease state when they are 2, 3, 4 hours away, from their primary care. And the next thing is they may have to airlift them out someplace because they don't have immediate care. And one of the things that they came up with is, remote patient monitoring could actually help with that connectivity. But it sounds like the CBOCs are part of that plan too, to try to just move care decentralized and closer to the patients as well. Right.
Well, I think CBOCs are step one, and I'm sure we're going to get a chance to talk about the remote patient monitoring and other kind of digital solutions to be steps 2 and beyond.
Yeah, that's great. So, Michael, from your perspective, tell us about your role at Microsoft and how it relates to DoD, VA, the federal government.
Yeah, so I serve as the Chief Medical Officer of Microsoft Federal, and that essentially means that I serve as a translator in chief for our healthcare organizations in the federal government that speak healthcare. That's their language. The Department of Veterans Affairs, comprised of VHA, VBA, and the cemeteries, largely speaks our language of healthcare. They don't, they do have massive technology investments and a big OINT shop, but our goal is, and my goal, is to help translate the language of providers and patients and ancillary staff, nurses, and so forth, into our technical teams that I do believe can provide immense value long term. I think technology has shown time and time again, when it's implemented appropriately, that it can, cut down on workloads of providers. We all know that provider burnout is a massive challenge, not just for VA, but the whole healthcare industry in our country. It can enhance patient outcomes when it's implemented, when technology is implemented appropriately, and it can push the provider even outside of the 4 walls of the hospital. And Scott was talking about CBOCs. It's a prime example, right, of getting healthcare to the community, and technology is a major part of that. But I think what we realized at Microsoft is, while we speak technology pretty fluently, we don't speak healthcare all that well. And I think that's changed over the past several years. We've made those investments, and our goal is to see our technologies leveraged so that they can actually enhance patient outcomes. And then ultimately, the grander idea is, the human condition all up, right? It's not just about healthcare, it's about health. Right. And I think you and Scott were talking about remote patient monitoring, and I think the genesis of that sort of technology is the realization that healthcare, or providing care within the 4 walls of a hospital or even a clinic, right? It needs to go beyond that, and wellness and mental health and these aspects that remote monitors and sensors and home-based healthcare or health can all contribute to. And that's an area that Microsoft obviously is keenly interested globally in, as being the platform that helps support those mission critical workloads. And you asked specifically within the federal government. It's no, it's certainly no. We're not fooling anybody. We support pretty much every government agency, whether they're healthcare or otherwise. We're a stalwart in this industry, in the technology industry. And I was talking to someone earlier today, and they asked me why. What does that mean, and why is it important? And I said, the government has made, just like Microsoft has been around for 40 years, made a tremendous amount of investments in legacy technology. We talk about Vista, CPRS at VA, or other EHR technologies. And much of that, or a large portion of those technology investments happen to be on Microsoft technologies. What we've had to do as a function of survival of our company is learn how to integrate the past with the present.
Yeah.
And I think that's the unique value proposition, right, that Microsoft brings to healthcare, which is healthcare has a lot of legacy tech. Some call it tech debt, but the reality is, in this transition, the shifting towards those companies that have had to do the same with our own product stacks. We can't just get rid of SQL as a technology and make, pivot all the way to doing Spark-based analytics as an example, right? We can't just pivot wholesale. We need to incorporate those new technologies and legacy with our own. And that's very much in line with the mission of many of the healthcare agencies, whether they be HHS or VA, DHA, and all the operatives of HHS is very much in line with the investments that they're making today.
Yeah, the one thing that's interesting that you kind of pointed out is physician burnout. But a stat that keeps on going through my mind, which I thought was phenomenal, is that in Q4 of 2021, we lost 177,000 providers that left the workforce, right? And of the 45% of the remaining were 55 years old or older.
Yeah.
Then we're graduating 10,000 people to be 65 every day. So people are getting older and sicker from that, with less ability to be able to be taken care of. And then you take on top of that, if you've got, you're 2 to 3 hours away from your primary care, right, on top of it, and you've got less to take care of it, we don't automatically jump and say that technology is going to solve everything. But in this case, technology is needed to be able to bridge the gap. Physicians don't need more data, right, from that standpoint, but to drive and make their job easier from this, data is going to play a really integral role in getting really early assessments, signals, situational awareness that's occurring inside that home, to be able to feed it to AI and machine learning, right? To make, Dr. Wise's organization's job much easier, right? To be able to, if people are doing okay, leave them alone from that perspective, right? If people are, falling off and decomping, the one thing, this is not about me, but the one thing I'm really excited about the data side of this, is it allows us to move from reactive care, like making people get sicker and being picked up by an ambulance and going to the emergency room, to now more proactive care and what I call just-in-time care. So if you have early data coming from the home, you may be able to respond 2, 3, 4, 5, 7 days in advance, with somebody to try to get them back on track, and use fast response teams, right, to do that. And data is going to play a really key role. Now, back me off of my position a little bit, because that's a really insensitive role, right? When you're talking with patients, you're not talking about patients and data, and you just see them as a number, but it allows us to be able to highly personalize care for them, right? So we can play a more, I think, personalized and appropriate role proactively, but we need that data insights to do that, right, as well. So the one thing I'll just say really quickly about Microsoft, I agree. I don't think people go through and look to Microsoft and think, they're our partner in healthcare, right, from that perspective. But they are, because the role that's going to be coming, and is coming now, is that interoperability, that data, that sharing, that ability to create personalized services, just-in-time care, requires that platform to bring it all together.
Yeah.
Right.
Yeah.
I think
you're absolutely right. And I think, when I think of physician burnout, you mentioned and you rattled off a bunch of stats, right? This is just a confluence of factors that all lead to a place that we're not all that thrilled about, right? Patients, longer wait times for patients, a hot button issue for the Department of Veterans Affairs, right? More physician burnout, a hot button issue for the federal government writ large, but also the healthcare industry. And then we all know with an improved or increased workload that you can actually stress physicians, staff, nurses, et cetera, into a point for declining patient outcomes. We know that. And so the question is, yes, how does our technology play a supportive role so that we can remove the documentation burden on physicians so that they're not sitting around with a computer interface between them and a patient, which, happens all the time, right? A doctor will go to the corner of the room and start documenting, and the patient sitting behind them and says, hey, the veteran will say, hey, treat me like a human.
Yeah.
Right. Ken, I'm looking at the camera and talking to you. I'm not looking over here. And that's exactly that reduces patient satisfaction or veteran satisfaction. And the funny and the wonderful part about this is that we actually do have wonderful technologies that are able to do things like we call ambient intelligence, which listen to the conversation and actually dictate the note for you. And it turns the physician into the approver again of their note instead of the scribe. And I know that we've made a lot of investments in scribes, and dictation software goes a certain way, but actually pushing it all away, removing this keyboard interface to healthcare for physicians and nurses. And that's something that we've done with a Nuance acquisition. So Dragon Ambient Intelligence is that technology. And then you mentioned importantly, healthcare has a data problem, and it's rooted in a couple of issues, right? The first is siloed data. And I believe that our platforms, and if leveraged correctly, can break down data silos. And then a scale problem. We're talking about multiple petabytes of data, tens of petabytes of data for an organization like VA. And the computational power that's necessary to actually glean any sort of insight, like you were talking about, Ken, is like getting to proactive is immense. And there are very few technology organizations on the planet that have that computational power to do even basic queries, right? To say, does Kent have diabetes and does he need follow-up, as an example, right? You were talking about looking over a patient population of 9 million patients. So it becomes a robust computational problem, and we have those resources. Sorry, Scott.
Kent, two more of those challenges. You each touched on one of them. One is today, at least in our organization, Microsoft, I'm sure is further along. We're still looking at data that is historical, to be sure. We're kind of catching up to just-in-time care, Ken, as you talked about. But what we're really after, right, Michael, is data that is predictive, where we can identify an impending problem before it happens in the patient's home or wherever they happen to be getting care, other than in a clinic like ours, for example. And then the other really kind of discouraging point about all of the healthcare providers that left the industry after COVID, we know that a large portion of them didn't come back, may not come back. But the other thing is, as we all have heard many times, is the number of medical students going into primary care residencies continues to fall year after year, right? For financial and other reasons, so many are choosing subspecialty careers. But with that continued decline, we're not going to be able to solve the access problem at VA or anywhere else without the use of technologies, though, that allow us to do more and more of the care remotely rather than in person.
Right.
And it's the right care. It's not just more care, right? Access is the right care at the right time for the right indications. And I think that's something that when we talk about, real-time data coming in from wearables and other technologies, right? And some of these are by the way, these are FDA approved continuous glucose monitoring is a prime example, right? These aren't I think a lot of people when we mention, remote patient, they think of their Apple Watch or Fitbit, right? I think we're really talking about
Or a Bluetooth scale or a blood pressure or something,
right,
right?
but
Right.
there's
Equipment you got
also
to ship out.
technology. Yeah, there are technologies out there that are far more medically inclined than those that come to the front of our mind when we think about remote patient monitoring. And the reality is that realizing the promise of those is not just saying, hey, I can get a patient in here when they're having a problem, but it's also, Ken, you alluded to this earlier, and I'll mention it again. It's saying you don't need to come in. I'm fairly confident that we don't need to leverage healthcare resources because your numbers look great for whatever the indication is, right? In medicine, we've really practiced this. Oh, if you're a diabetic, you need to come in this schedule. We'll start with quarterly, we'll space you out to biannual, and then we'll move on. What the technology will help us do is reimagine care pathways, and that's the exciting part, right? Which is we can actually get down to the clinical pathways and ask the question: do you actually need to come to the doctor? And then when you do, you'll show up to Scott's office and he'll say, you're coming here because these are the problems, not asking the patient or the veteran, why did you come in again?
Or maybe they're coming in, because, they're lonely, right? And that's a different resource, right, to do, instead of having to see the primary care. Maybe it's more behavioral health that needs to be done.
Well, and that just speaks to, kind of the other social determinants of health that impact people's chronic conditions, and technology is helping us tackle those other social determinants as well. But what's interesting is, and there's a whole nother episode probably, Ken, but Michael kind of referenced, people are, and I talk about patients and providers both, are so ingrained with, if you're a diabetic, you have to come back every 3 months, and it's almost regardless of how well your diabetes is controlled, because that's what we always do.
Yeah.
And that really gets to the heart of value-based care. Are you delivering the appropriate care via the appropriate modality at the appropriate time, or is, like in the past, is it just a revenue driver? And that's really not what value-based care is about.
That's what I was going to ask you. Like, when my cardiologist makes me come back in 6 months, I pretty much know that it's probably for a meds check, right? More than anything else, from that standpoint. But it also, does it have a revenue component to it as well?
Sure. Absolutely.
Like you could do another ECG and bill for it after 6 months, right? Or something like that to do it. So
it may be, but the good news is that the VA, that some of the incentive, right, is removed, because the VA is an integrated health system, and both the payer and the provider, and that's but also, okay, let's say we can't get rid of the clinical guidelines that say you need to come in every 6 months, Kent, but do you need to come in person?
Yeah.
Right. And so what type of care it becomes, because we have more options at our disposal now than I think a lot of folks give us credit for. And we are doing a lot of things in healthcare still reflexively, because that's the way we've always done it. And this will allow us, providing the right data to determine the right care in the right area, the right type of care as well. And when and how, all these questions that have plagued us for a long time, because we all know as physicians, like half of the patients that come in on your page, it's like, oh, okay, yeah, you're doing great, good to see you in 6 months. And then the other half of the patients are, well, you haven't come in 6 years.
Yeah,
right?
I agree with you. I sit in front of 3 big screens all day long, and there is no reason why I need to get out of the chair other than be healthy and go walk, right? To go to the cardiologist.
Big reason though, Ken. It's a big reason. So
I get it.
Let's not discount that.
Nope. Right. It's good to get up. But I could easily have taken a visit like this with my cardiologist, right? To be able to do a meds check and stuff. Let's swing over to, from the doctor side, the physician side, remote patient monitoring has been out there for a long time, right? From that perspective. It's now, I think, coming into its own. People are transitioning to call it more virtual care or virtual first. And part of it's because you're now starting to really, truly understand the individual and bundle services together for them. It could be social determinants of health. It could be telehealth. It could be RPM. It could be food, right? That's part of it, or meds check compliance. That's where I think a lot of this is growing. How does that, especially when you've got the C box out there, and now you're providing care to the moving care closer to the patient. How does RPM help you, or how can you help the patients with RPM, especially there at Valor?
Well, Ken, as you know, a great example of how you can bridge some of the care gaps leveraging technology is the remote patient monitoring contract opportunity that our companies have jointly bid on. The ability and the ease of veterans using medical peripherals at home. We talked about some of blood pressure monitors, glucometers, pulse oximetry devices, for example, and wearable devices, as Michael mentioned, smartwatches and heart monitors and so on, all of which can be connected virtually to a veteran's electronic health record, specifically his or her file, allowing us to keep an eye, if you will, on veterans' health without physically laying our eyes and or our hands on them in the clinic or the office. I'll give you a second example. At Valor, we're working on a white paper now for VA's Office of Healthcare Innovation and Learning on a new care model pilot that incorporates, and you mentioned it, Ken, a digital first strategy where depending on the clinical acuity, not only is the first visit to a primary care provider a virtual visit, but virtual visits actually become the default visit type over a traditional in-person visit. Again, assuming a patient's complaint or medical history doesn't appropriately dictate an in-person or hands-on examination. So it's one of it, and we can circle back to it a little later if you like, but it's probably for me and in our industry right now and our business, kind of this digital first strategy using technology to fill healthcare gaps is really kind of one of the most exciting things on the near horizon for us.
Yeah, one of the things I'm really excited about, I've been doing this for, quite a while, like you guys have as well, but, to now start seeing and hearing the words coming out of people's mouths that now start making, like it's starting to get into normal, everyday, exercises for people. When I envisioned my parents, right, in rural Iowa, like almost like a VA veteran that's in a rural area as well, how do they really adopt technology? Am I having to make them go get a smartphone and and download an app and try to pair things? And that wouldn't have been successful in our household. But now with the pandemic that's occurred, it's taken everything that we're trying to push along and it's accelerated it, right, from that standpoint. And the cool thing about the marketplace is that a lot of new technology, I call it omni-channel, has come out there to allow us to be able to engage people on how they want to be engaged. It could be through Alexa, it could be through a smart TV, it could be through a wearable device, it could be a hub device, very passively taking information. It doesn't mean you had to go buy a $1,500 smartphone or a $1,000 smartphone, right, to be connected to your doctor. It means that you could have things that are already sitting in front of you, in front of your easy chair, right, to be able to connect and converse with your doctor. And so you don't have to struggle, right, to try to get to the office and go see them every 3 months, where transportation could be an issue. One last thing I'm gonna say really quickly. The biggest thrill my mom found out for her that caused her, it almost brings tears to my eyes, that caused her independence, is she was really super upset because my aunt had to come by and pick her up and take her to Hy-Vee, right, to get groceries every week. And she didn't have independence to do it herself. She couldn't drive, right? She didn't know anything about Uber. But when she found out about she could order groceries online and have them delivered to her front door, right, and didn't have to ask anybody about it, it was like nirvana to them. It was like independence, right? So I think there's a form of fearing sometimes the technology that comes in, but then embracing it after that as well, right? That it creates independence.
But you're absolutely right, because when we think about Michael and I are different age demographics, for example, but when I think about, okay, if I think about a quote geriatric population, well, 10 years from now, the geriatric population is going to be so much more comfortable with and experienced with digital technology that.
But I'm still gonna want it to be simpler, right? I'm still gonna want
for
it
sure.
to.
But
I'm not
but
gonna
you
want
won't
to sit
have
there.
kind of quote the elderly or the geriatric population today, like my mother and yours maybe, who are just resistant to technology because
Yeah.
you know it's just too, can't get their heads around it. And I think that's going to improve, you know, in the near term.
You know what
Yeah.
was interesting, really quick, I'm gonna go over to Michael in a second, was the study that I saw yesterday was, you know, the people that are the most dependent on technology today, you would think it's the millennials and the Gen Zs and stuff like for social media. They're finding out it's the seniors, right? The seniors are using it, you know, to turn on lights, to open doors, right? To do a lot of different things that have been pre-set up with them and stuff. It's that generation where technology, if it's passive in the background, like, you know, medical technology and remote patient monitoring, it's just easy like this to get on and talk to your doctor, can be incredibly independent and freeing of people,
Yep.
right, as well.
Yeah. No,
Sorry, Michael, go ahead.
No, I agree. I think, you know, to Scott's point, or the geriatric patient 15 years from now will be much more wired, we'll say. That's my father's term. My father is also one of those people adverse to technology. I thought I was doing my son duty of buying him an iPhone, and instead I spent 3 or 4 hours on the phone, on the other phone with him, setting up his iPhone. So that one backfired quite a bit. But you know, I think we still do need to take into consideration, though, that there is a digital, we'll call it a digital divide, right? There's a digital divide between those who have access to technology like this, and those who don't. And when I was speaking to a former healthcare executive of a large integrated health system in the commercial market, many years ago, we were talking about remote patient monitoring, actually, and that was in its infancy at the time. Like we were really very early. And I said, because we cared for an inner city population, I said to her that the benefit of this type of technology on those folks that have access to healthcare issues is far greater than it will ever be to folks like me, who can get in my car and go to that, you know, have access to a doctor. It really is such a monumental benefit to those who have transportation issues. I think you alluded to getting an Uber is expensive for folks. You know, getting, you know, the C-Box, they do part of it, right, by putting the healthcare in the community, but there's still a transportation challenge, right? And the answer to many of these issues is, quite frankly, is to provide the care at a distance, right? So we still do need to make sure that when we, you know, get this technology in the hands of folks, that we're doing it to the right patient populations that can actually benefit the most from it, because it's inevitable that there will be, you know, certainly those who have smartwatches, Fitbits, and scales, continuous, all the tech, and then there will be folks who don't. And the reason why that matters is because it becomes very difficult to standardize care pathways. And we all know healthcare loves standards, but it becomes difficult to standardize care pathways when the data sources are variable, right? It's a mathematical problem, right? And if I have, you know, half of my diabetes patients are able to afford this sort of continuous glucose monitor, or half of my obese patients are able to afford the Fitbit and remote patient monitoring, and the other half aren't, I can't standardize clinical pathways that have historically loved to stay in the swim lanes, right? So if we're going to ever hope to make a dent in these healthcare pathways that actually drive a majority of cost in healthcare, we're going to need to make sure that the adoption of the technology is equitable and fair, because these are the core groups that we're actually trying to help, right? And in the VA, it's a prime example. The VA skews more male, certainly more elderly, right? All of these things we know true. Comorbid conditions.
More rural, right, as well,
Yep.
you know, from that as well.
20% of the
Right.
of VA, of veterans
Yeah.
are rural. Yep.
I think that's the biggest thing as a technology person and solution person that I had to get used to coming to this industry is, you know, well, I like to think outside the box.
Mhm.
And, you know, healthcare likes to think inside the box, right? From that, they're
Healthcare
like
loves
standard,
loves boxes.
yeah,
We love
standard
boxes.
protocols to be able to do that. But sometimes if you've seen one patient, you've seen one patient, right? From that. So people engage different ways. My parents certainly did, right? And just giving them all tablets and say, log in and do this and do whatever. I'm like, first of all, I don't use tablets. Second of all, I don't know what a login is, right? To do it. So my thing is that you've got to embrace people on their terms, right? You bring care to them. So, Dr. Wise, I know we're going to wrap up here in probably about 4 or 5 minutes, but, from your perspective, I think you're maybe not representative of the typical physician that might be out there. Maybe you are, but, are physicians open to having, patient data coming in from maybe AI or machine learning systems? I saw something on Microsoft the other day, like when somebody walks in the room, the chart automatically changes to the nurse, in the room, so they don't have to go log in automatically. They can spend more time. They can leave the laptop on the side. It can use nuance to record it automatically. AI can be off to the side going, did you ask him about if he needs a medication refill? Did you ask him about this? Are you as a physician open to having that type of technology prompting you and helping with you, or does it impede you in any way?
Well, personally, yes, but I think obviously your question is, okay, what about the average primary care physician out there? And I think the part of the answer is analogous to what we just described about a senior or geriatric population, meaning that with each decade, let's say, the older physicians, right, what would have been old school physicians, they've already grown up with this technology. So I don't think there's going to be near the barrier to entry, if you will, for physicians each successive year to leveraging technology. And I think if we're able to get there pretty quickly, and I think we will be, then it goes back to kind of this digital first strategy, if you will. I mean, look, CMS has been piloting different models for true value-based care for over a decade. We all know that our country spends by far more than any country in the world on healthcare, and yet in clinical quality and outcomes, we rank somewhere around 22nd in the world, and that's a shame. As a healthcare system, we are not delivering quality and value relative to the dollars being spent. And I think using technology to deliver care, to improve the experience for patients and providers, to measure quality and to reduce costs are going to help us, achieve healthcare's quadruple aim. Not only is it going to be the fastest way, but it's going to be the requisite or necessary way, I think, to get there.
That's what I love about going into this, this VA, RPM potential program that's coming up, because we're at a point where adoption is changing, right? Both on the clinician side, but also on the consumer side or the patient side, right, as well. New technologies coming into place, new platforms are coming into place, right? How people embrace technology, like shifting to more consumer-based healthcare and payer-based healthcare. All of that is an opportunity now to really get I think, some phenomenal results, right, from this, if they are personalized and targeted appropriately to the individuals to maximize, adherence and compliance and everything that comes with it, right? To provide, the services and solutions they need in a more proactive way. That's what I'm eagerly enthusiastic about. Right.
Yeah, it's going to be. I mean, we got to get there, obviously, and we've got 2 feet on the path today. But it's really going to be, I think, revolutionary or transformative, both for the patient, Kent, as you said, and for the provider. You're going to have more, professional satisfaction. Your outcomes will be better. Patients will be healthier. So everybody wins.
Yeah, I think with your clinical leadership, from that, I think we'll get there. And then, Michael, with you, from the Microsoft perspective and being able to, basically, you're comfortable with this. Microsoft's comfortable with this, being in the background to make sure that data flows freely and that information is given to the patient and to Dr. Wise and company to make their jobs simpler and easier. Right from that, I think it's a fabulous partnership, right, along with the VA. So I'm just going to go out. And Michael, anything else in closing before we
No,
close up today?
That's a great way to close it.
Okay. Dr. Wise? anything
No,
from
very
you?
good. Appreciate the opportunity to join you and participate. An
Well,
important discussion.
Yeah, once again, thank you so much for being part of the new normal. And we are going to have another new normal in 2 weeks. I want to thank Dr. Wise and Dr. Uohara for your participating, great insights. And you can find details on our upcoming episodes at newnormal.buzz, and have a wonderful day.
Thank you.
Thanks, guys. Really.